Hello, my name is Miriam, and today I will be discussing case connection 4, and within it I will be discussing case 2 and case 3. So let's begin with case 2. Case 2 is about a 4-day-old infant. She was born at 5.9 pounds and was delivered vaginally. Results from her newborn screening demonstrate that she has high levels of phenylalanine in her blood. The level was about 6.6 when it's normally between 1 to 2. So a diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis, and her parents also deny a family history of PKU. So the first question is, as a consequence of this presentation, which amino acid may become essential? So in Unit 4, week 14, we learned about the metabolism of aromatic compounds. We saw that phenylalanine gets converted to tyrosine, and tyrosine is normally a non-essential amino acid because it is created from the conversion of phenylalanine, and phenylalanine in this case is the essential amino acid. So phenylalanine is converted to tyrosine, making tyrosine non-essential. However, when phenylalanine is not being broken down or metabolized to tyrosine, tyrosine then becomes an essential amino acid because the body is not creating it itself. So the answer to the first question is tyrosine becomes essential. So the second portion of this question is that phenylalanine dietary restriction therapy was initiated 14 days after the baby was born, and then phenylalanine levels dropped within 2 normal ranges. So what are the potential causes of the presentation of fetal phenylketonuria in this baby? So phenylketonuria occurs when one of the enzymes or cofactors in the metabolism is not functioning properly or is lacking. So the enzyme that could be lacking would be phenylalanine hydroxylase. This enzyme is used to turn phenylalanine into tyrosine. Because phenylalanine is not being converted to tyrosine, there's elevated levels of phenylalanine in the blood, which is why we saw that in our patient. Another potential cause for phenylketonuria is a lack of the BH4 cofactor. This cofactor is used and required for the metabolism of phenylalanine to tyrosine. So those are 2 potential causes. So then a test was done on 2 patients, patient B and patient A. They were given BH4 loading tests, which both patients ingest synthetic cofactors, and then they're tested to see what phenylalanine levels, if they change after this ingestion. So I have the graph printed, but it's not in color. So patient B is this line right here with the squares, and patient A is this line up here with the diamonds. So the question is, how would you summarize the results of this test for patient A versus patient B? So this test is used to identify if patients have a problem with the cofactor BH4 or if it's the other enzyme in the pathway, such as phenylalanine hydroxylase. So this loading test was done on both patients. They were given the synthetic cofactor to determine if it was missing. So we see in patient B that as time goes on after the BH4 is ingested, the phenylalanine levels go down, which means that phenylalanine is now being metabolized in the body and broken down. And so the levels are going down as BH4 levels go up, which means that the cofactor BH4 was what was missing in this patient, in patient B. So when BH4 was added, the process started to go more normally, and phenylalanine was broken down. Versus patient A, whose levels after ingesting the BH4 kind of go up or stay the same. This indicates that the phenylalanine is not being metabolized in the body after the BH4, so that this means that it is not the BH4 that is the problem in this pathway. It could be the enzyme phenylalanine hydroxylase. So that is the difference between these 2. So patient B is lacking or doesn't have enough of BH4 cofactor, and patient A has a problem in the enzyme and is not affecting the BH4 cofactor. So that is the answer for case 2. We'll move on to case 3. Case 3 is about a 47-year-old man who is suffering from pain in his great toe on the right side. There's no apparent trauma, and upon physical examination from a physician, the diagnosis of gout is made. And gout can be caused due to several things. We are given some test results, the plasma urate levels in this patient and the urinary uric acid levels of this patient comparative to the normal levels that were given. So the first question is, what is the best explanation for the presentation of gout in this individual? And so we're given three options. It's either overproduction of purines, decreased salvage of purines, or decreased urinary excretion of uric acid. So my opinion for this case is that the root cause of gout is the decreased urinary excretion of uric acid. So high levels of plasma uric acid build up, and it can cause gout or other disease risk factors. The main reason for a buildup or higher levels of uric acid is either higher synthesis or lower excretion, or both. So that means that your body is either producing too much uric acid or that your kidney is not excreting enough uric acid. So high levels of uric acid in the blood cause deposits of needle-like urate crystals in the joints and other tissues. This can cause severe pain and inflammation. Normally, uric acid will be excreted in the urine. However, if someone has kidney disease, it could lead to hyperuricemia, which is the elevation of uric acid. So purine is normally metabolized into uric acid and excreted into the urine. Purine being overproduced wouldn't directly lead to gout if it were being metabolized and excreted properly. Also, if purine isn't being salvaged, then it's not being metabolized or broken down into uric acid. So it makes the most sense that there is a decreased excretion of uric acid in the urine that is causing the buildup and leading to the gout. Also, the data presented shows that the urinary uric acid levels of this patient are 215, when normally it is 413 plus or minus 78 milligrams per 24 hours. So this is significantly lower in our patient, which means that not enough uric acid is being released into the urine. So the second part of this question is, after further discussion with the patient, he tells you that he recently switched from diet soda to regular because he read that fake sugar was bad for him. He tells you that he drinks between 4 to 5 liters a day. So our question here is, what is the potential impact of this dietary modification on the presentation of gout? So other causes for gout are diet related. Diets high in purine foods such as meats and seafood, or beverages that are sweetened with sugar such as fructose, like soda, lead to increased levels of uric acid. So we know that our patient has switched from diet soda to regular soda, which is high in fructose. So we now know that that dietary modification could be leading to the increased risk of his gout. So it is really important to inform the patient of that risk, and that the soda intake is possibly what is leading to his gout attacks. He should be advised to reduce that and see if the gout attacks lessen. There are some foods that also help prevent gout, and the patient should be advised on these. There are fruits and vegetables, whole grains, soy products, and low-fat dairy products that really do help lower the uric acid levels in the body, which could help lessen his gout attacks. So it's important to tell the patient all this information and let him be aware that the soda and the dietary modification that he did could be the reason why he has more gout. And that there are foods that could help him lower his uric acid levels, so that he could, to higher his urinary acid to help lessen his gout attacks. So that is my answer for both case 2 and case 3. Thank you very much.